My name is Anika Tenneti. Today is July 10th, 2024, and I'll be presenting on minimizing chronic kidney disease outcome disparity in low-income countries. As a note, from now onwards, I'll use the abbreviation CKD to refer to chronic kidney disease and LICs for low-income countries. First, I'll introduce myself. I'm a rising sophomore at Doherty Valley High School in San Ramon, California. I'm deeply interested in biology, medicine, and the global implications of these fields. So in the future, I intend to pursue a medical career while striving to improve healthcare equity. To further my passions, I actively participate in my school's biology club, volunteer with the Red Cross, volunteer at a local nursing facility, and explore global health issues with a hands-on approach. And in this presentation, I'll reference some of my own work. For a week in April, I shadowed Nurse Visimpelli, a dialysis nurse at a reputable Indian hospital, and later interviewed her about the healthcare issues I witnessed firsthand. Now, I'll begin. Today, I'll identify why patients in low-income countries, LICs, have poorer chronic kidney disease, CKD, care outcomes. Based on these root causes, I'll propose specific yet multifaceted approaches to minimize the overall disparity. I'll begin by providing context about CKD and then about its general relationship to LICs. CKD is a deterioration of kidney function over 5 stages like so. Treatment goals are identified based on the stages, but goals are not always met. When this happens, two poor outcomes result. These are a rapid rate of disease progression and preventable mortality. Why are these poor outcomes significant? Well, a rapid rate of progression leads to severe stages sooner, which harms a patient's quality of life. Preventable mortality is significant because CKD is and will continue to be a major cause of years of life lost, as seen to the right. Hence, preventable mortality can be redefined as premature mortality. But where does disparity come into play? Well, disparity in CKD outcomes emerges because patients in LICs more often experience these poor outcomes than those in high-income countries. Such jarring differences certainly suggest that socioeconomic imbalances are at play here. From consulting the timeline again, it's clear that they affect diagnosis and treatment systems in order to make rapid disease progression more likely. They also affect the systems of RRT, which refers to dialysis and kidney transplant, to make premature mortality more likely. I'll narrow this down soon, but from this we can certainly grasp how relevant socioeconomic factors are to the solutions that will ultimately elevate CKD care for all. Thus, CKD outcome disparity must be framed as a global health issue. To further emphasize my topic's global nature, I would like to point out that poorer outcomes disproportionately harm LICs. After all, in more severe stages, patients can't work, and when their family members are needed as caregivers, neither can they. This is a lost productivity that exacerbates both individual poverty and already high economic burden. Similarly, because severe CKD stages are inherently costly, they exacerbate healthcare burden. Now, I'll narrow down the general causes of poor outcomes that I've established thus far to propose specific strategies to approach the outcome disparity. First, for the cause of the premature mortality disparity. That's likely the prohibitive cost of RRT, as proven by the statistic to the left. So how can RRT be made more affordable? First, optimizing government funding is imperative. Rather than just increasing funding, directing it towards specific goals has great impact. When the goal was covering dialysis at reduced frequency but for all patients in Sudan, patients continued dialysis for longer. Experts also advise LICs to reduce unnecessary spending on RRT equipment to make it cheaper. Finally, kidney transplant should be promoted because it's less available but more cost-effective than dialysis in LICs. To do so, countries must encourage potential donors and improve organ preservation. Patients might be able to afford some components of RRT and still die prematurely. This is due to complications. First, for ways that dialysis machines access blood. When patients can't afford specialized surgeries for vascular access, they permanently use otherwise temporary catheters. This increases infection risk. To minimize this complication, governments should fund the switch to peritoneal dialysis, a new, more affordable form of vascular access. Another aspect of RRT that patients often can't access is follow-up after kidney transplant, and that greatly worsens the success rate of the first transplant. As a note, my source for these facts to the left was Nurse Visimpelli. Anyway, to promote follow-up, it's worth increasing funding for long-term checkups. So far, the solutions I've covered are based on RRT. While these are more than necessary, they only resolve poor outcomes at the stage of kidney failure. It's worth recalling here that later stage CKD disproportionately affects those in LICs. So now I'll turn to solutions that reduce progression to later stage CKD altogether. Because medications for risk factors like hypertension and diabetes stabilize renal function when administered early, we must boost medication access. This can be done by ensuring that they are included on insurance provisions and produced within the country to reduce patient costs. Yet, to even seek out treatment this early on, patients must know that they have CKD. However, many patients in LICs don't, due to poor early diagnosis infrastructure. Hence, implementing early screening systems could effectively slow CKD progression. LICs can fund transport of patients or pay couriers, as labs in urban settings have better screening tests. Screening guidelines, made with HICs in mind, must also be broadened to account for LIC specific factors. In the same vein, risk algorithms to determine populations to screen and further research on unknown causes are essential in the long run. Now that I have examined and proposed solutions for the disparity in CKD outcomes based on country income levels, I'll provide you with my key takeaways. Overall, patients in LICs tend to have poorer outcomes of CKD care, and this is disproportionately problematic. As for a solution, the disparity must be approached from multiple angles, considering the vast array of strategies I've proposed, all with different goals. But no matter what exact strategies LICs implement, government support is inevitably needed. Unfortunately, only around 60% of LICs even consider CKD as a health priority. This is where public involvement comes in, and it can do wonders. Although the Nigerian government was reluctant to address CKD prior to 2017, the persistence from the local nephrology association led to them funding the first 6 dialysis sessions for all. This is a compelling reason for us as the public to act upon this issue. And if you would like to get involved, the best way to do so is with the International Society of Nephrology. They advocate for CKD prioritization and provide support to LICs. You can promote their campaign to start conversations on social media. You can also participate in the activities on their website or even lead your own. Finally, donating to this organization and encouraging others to do so goes a long way. Here are my works cited. And finally, I'd like to convey my sincere gratitude to Nurse Visimpalli for allowing me to shadow and interview her, and to the staff at GHLC for the opportunity to present on this topic. And thank you for your time and attention. Here's my email address if you have any questions.